Thank you, Amit. In fact, it's my privilege to introduce the young dynamic surgeon from Ahmedabad, who's been working as both retina and ocular trauma surgeon in Nethralaya Super Speciality Eye Hospital. In fact, he is the son of one of the person who has made the Ophthalmological Society in Ahmedabad taken into a different level, none other than Dr. Rana. So in his young age, I think I've been keep seeing in a lot of medias nowadays. But the most important in this young age only, he could able to patent few of the equipment, mainly Rana and Shah's self-sustaining serial tuck IOL. Probably it is designed to fix on the sclera without any need of any suture or glue or groove. Of course, we indeed very happy to be him here. I think his case presentation will be, I'm seeing and waiting which sort of case he's going to present. Over to Dr. Partha.
Thank you so much, sir, for this kind introduction. So, here I am sharing my presentation. I have a kind of straightforward presentation with cases. I'm not going to quote so many of the studies here. So, uh, we are going with our first case. Like it was a 58-year-old male, DV from past few months in left eye. He was diabetic and hypertensive from past 5 years. There was a NS2CO in left eye, and the vision was there was a left eye vision. The vision was 612, and there was a tiny hemorrhage was there just beside the fovea, and we advised the patient for OCT, and OCT showed a PD like this, and we asked patient for anti-VEGF, and we asked patient to wait for some time, then go for cataract surgery. But patient was like, no, I should go by myself. He just went to another doctor, and he just got operated there, and there was a breakthrough bleeding there, and the PD increased, and patient came to me after a month. The hemorrhage was partly dissolved there. They injected one anti-VEGF there, and then we started anti-VEGFs at our clinic also. And the case two, there was a 62-year-old male DB from past few months in both eyes, non-diabetic and hypertensive from past 7 years. There was NS3. OS vision was 624 part. As we can see here, there was a CNVM there, and there's a large PED. We stopped the patient there for cataract, but patient went ahead, and patient came with this after a month. So maybe related or not related, but we found the case like this. And then we started the treatment with anti-VEGF, and patient was really angry with the cataract surgeon. Even though patient knew that he had a pathology in his eye, he was angry with the cataract surgeon that he did some mischief there. And there's a case three, there's a 60-year-old male, and the DB from past few months in left eye, diabetic from past 6 years, and hypertensive from past 5 years. There's an NS3 VSE, and vision was around 612. And as we can see here, there was a tiny retinal arterial macroaneurysm there. We explained to the patient, and with the ERM was also there. With explained prognosis, patient went for the surgery, and post-op there was a sub-ILM hemorrhage. It was pre-retinal, and there's a breakthrough bleeding, and it was related or not related to the cataract surgery. But in a nutshell, in COVID times, most of the general ophthalmologists are avoiding fundus examination, but thorough fundus examination is mandatory before any cataract surgery. We can use non-magnetic fundus cameras or ultra-wide field or fundus imaging systems. There's a proper informed consent is always necessary, and with consent, we have to even explain patient properly, and we have to take the patient's trust before going for any kind of surgery. And any eventful circumstances, we have to support our colleagues, because so many times, like when patients are angry, like we can see in social media and print media, most of the times what is happening, like we are not supporting our colleagues at some point, and then this thing happens. So when sometimes we see it can from far, it can be like this, but when we see from near, it can be like this. So in current times, before saving the world, we have to save our hands from burning first, and always consult a retina colleague in case of any doubt. it can share responsibilities, and there can be better outcomes. And always prefer macular OCTs before cataract surgery. I'll conclude my presentation here because so many of points which I wanted to discuss have already been discussed in previous presentations. So thank you, Partha Vishwas sir and AIS committee.
Thank you, Parth. Wonderful 3 cases you have presented. We have our discussants, Dr. Malika Goel and Dr. Mohan Rajan. Dr. Malika, over to you.
Yeah, good case series. I'm just wondering, looking at them, what was the vision? We don't have the visual acuity data on these patients. So was the vision reduced? Number one. Number two, the fundus pictures are so clear that it looks as if there was no cataract. So if the vision was poor, then it was obviously not from the cataract. The cataract surgeon should have understood that there is something else. Then if you see the OCT, especially in the second and third case, they're pretty deadly. The second one is obviously PCV, and the third one also is showing a lot of changes. So I just want to know why the cataract surgeon would have proceeded with the cataract surgery when the media was so clear, and when the OCT was so also diagnostic. And what was the visual acuity change pre and post operatively? Is what I would like to know.
Pre-operatively, I have written here. Post-operatively, it was around 660 or less than that. And another thing, like this OCTs, if you can see there, like there was a little bit of signal loss there. And this kind of cases, like patient came through another cataract surgeon, and patient went to another cataract surgeon because we did stop them for cataract surgery, and we asked them to go for anti-VEGF when patient didn't wanted to spend anything for anti-VEGFs. So patient went to another cataract surgeon, some trust or somewhere where they are not doing much of the investigation for fundus. And after that, this thing happened. And this 3 patients I chose because 3 of them were asking like this was due to like some mischief has happened in cataract surgery, and it's just due to that. So we have to ask patients, we have to show them the OCTs pre or post-op, and this is just due to the progression of the disease, nothing because of the cataract surgery. They just wanted to sue the doctor, or they just wanted to just make a scene there, and we had to stop them. And most of the cases were happened in this trust hospitals nearby. So that's why I showed this cases.
So in these cases, you had already seen the patients pre-operatively. That's how you have the pre-op OCT.
Yes, ma'am.
So you had already advised retinal treatment, and they had refused already.
Definitely, ma'am.
There is no question of suing the cataract surgeon because you have already told them, and they have refused treatment.
Yeah, because some private surgeons sent this to me. I just advised them anti-VEGFs. They went to some trust hospitals and they got operated. And if you can understand, and what they do in trust hospitals.
No, so I understand, but the question of patient feeling that there has been some mischief doesn't arise because you have already told them that there is another problem.
Very true.
No, we do not know what the counseling has been done by the cataract surgeon. That is the problem. No. He doesn't know what's happening in the cataract surgeon. The cataract surgeon would have promised good vision. Yes. Unfortunately,
the patient has already contacted Dr. RANA, and he has already been told that there is a problem which will not improve his vision. The cataract surgery will not improve his vision. He has been told. Now, if he takes that decision, then cataract was also there. He cannot blame the cataract surgeon. Okay, second point which I want to make is when we are counseling such patients, our language needs to be little blunt. When patients are able to get violent or hostile or aggressive, we also, on the defense, when we are seeing such patients, we should tell them, cataract surgery karaye to vision nahi aata, chala jata. This is the word we have to say. If we try to be diplomatic and say, no, there is something at the back and we don't know what will happen afterwards, they forget all that. We have to say very bluntly that you will not get vision, you will lose vision, you will lose vision. When you say such words, that sticks to their mind and they will not go ahead with the cataract surgery. So we need to be blunt because they are also very aggressive when the results are not good. So we need to be blunt proactively, preemptively, not afterwards.
Yeah,
so
very true,
Malika. You've really scored that point very well. Yes, Ajay, you wanted to say something.
No, I just wanted to say, as a cataract surgeon, I mean, this patient went off, that's different. Now you have a fluid and you have given injection 1 or 2 injections, you still have fluid. when you do advise a cataract surgeon, would you want it to get totally dry before it takes for cataract surgery, or in between the injections, say maybe third or fourth injection, you still advise a cataract surgery? I mean, I normally do it this way. I mean, I keep the retina surgeon in conjunction. He gives an advising twice or thrice. Patient knows that the vision now is due to the cataract. But as a retina surgeon, would you advise that the whole fluid dries off, either it is a PCV or early PCV or even a simple CNV?
Yes, of course, the macular condition should be stable before you operate.
Absolutely.
Yes.
Definitely, sir.
Macular condition should be stable.
And by stability, what do you mean?
Can I make
Yeah, it
There
should be
will
dry.
a
It should be
persistent
dry.
fluid somewhere even after 3, 4, 5 injections, while the cataract keeps on increasing. So would you do it, advise a cataract surgeon to do it and then come back, let me continue?
Sir, in that kind of cases, like we found some of the cases like that, what we have tried, we have given an anti-VEGF with a tricot, and we have waited for a week or 10 days and then asked the cataract surgeon to operate and then come back again. We always explain them that cataract surgery is just a part of your treatment. Most of the treatment we are going to do it here. So don't forget after cataract surgery that you don't have to come here. There can be any complications. We explain them, proper consents are taken, patient has taken, proper trust has been taken, then we are asking patients to do like that. So that is the protocol we are doing, and we are trying a study also for that. So what kind of cases we are getting?
I think, it brings home a very important point is, even if it is a speck of hemorrhage at the macula, it has not to be taken lightly.
Very true.
Total imaging has to be done. A confirmed diagnosis has to be taken, and then to proceed with the conjunction, as Ajay very rightly said, with the conjunction of the retinologist. The retinologist should give a go-ahead. If a treatment is to be instituted, institute the treatment, let it stabilize, and then do the cataract surgery, telling the prognosis to the patient that it is not going to be 6/6 or whatever is the expectation. The expectation has to be realistic. I think an excellent case, Parth.
Can I make 2 points? Just 2 points, Partha.
Yes, sir. Yes.
No. A very nice presentation by Parth Rana. I just want to make 2 points. One is 100%. Lalit Verma was talking about in the beginning of the lecture whether all the anterior segment surgeons should do the OCT for all not only premium oils, for all cataracts. Preoperatively, OCT is a must. You can do it even without dilatation of the pupil. The OCT is a must for all patients. Whether it's a premium IOL or a toric lens or a regular monofocal lens, it doesn't matter at all. So you need to know exactly what is the status of the macula. Second thing is, many patients, as you rightly said, don't dilate now because of the COVID era. They don't want the patients to wait for long. But I think it's important to dilate, especially when you're doing the cataract surgery, for 2 reasons. One, I should know how much of dilatation is occurring for this particular patient before I venture into cataract surgery. Number 2 is, I want to examine the retina, not only the macula, but also the retinal periphery. Please understand this also. I think it's 2 important points Rana has beautifully mentioned in this. It's an eye-opener talk.
Yeah.
One point, if we are hesitant to do contact this 78D or 90D exam, an indirect would be very easy after dilating. You don't have to go very close to the patient in the COVID times. Indirect is much more safe and faster.
Absolutely.
Can I make one point?
Even in the slit lamp, Malika, even in the slit lamp, you have a shield and you're going away, and that's why I put it. That's why in the beginning of my.
But Dr. Natarajan, I find it very difficult nowadays with the patient wearing a mask. There is a lot of fogging which happens. With the indirect, it doesn't happen so much because the lens is little further from the patient's nose.
So I have now requested every patient to have a sticker for some time. As soon as they come near my OPD, I tell them put a sticker. Like I am putting a sticker, you also put a sticker for some time. Go outside and remove. And for surgery, I make it mandatory. They tell me it's all this thing, I'm not used to it. I said, it doesn't matter. Half an hour you practice before surgery, they have a gap, then I put it and come back at it. Because now I'm operating daily and I tell them this is what. So I think we have to train the patient. It is like, that's why I written this in the notes. That whatever cataract is blocking, that much will improve. And whatever, it's like milk and water together. You don't have a lactometer here to say how much you will improve after cataract. So I think the highlights, what you discussed on Partha's case were really relevant, where I think the patient should know, and counseling is very, very important.
Indirect for the periphery.
I just wanted to make to what Mohan Rajan sir said. regarding doing OCT in all cases of cataract surgery. I think Malika madam will agree with me that most of the retinal surgeons, if you do it proper examination with 78D and 98D, with a good clinical acumen, we can still pick up most of these pathologies. I do agree that if it is a drusen, then you can definitely go in. But if there is nothing, then actually it is subjective. Some surgeons prefer to do it, some may not prefer to do it. It's not compulsion that we have to make it in all cataract surgeries. And secondly, when the changes already happen, that is the morphological changes, what we have to look in for is the biomarkers. What kind of biomarkers? Like say, for example, SNPs, complement factor H. These are the molecular biomarkers which tell that in future, this patient is going for AMD. Actually, that will change the way what we are looking at the retinal diseases now. But what we are looking into the OCT is when we already have a lesion. So what is required in these cataract surgeries, whether this patient is going for that so that we can choose whether it's a monofocal, multifocal, accommodative, trade-off, end-off, all those things. So this is just my point and suggestion.
Very dense cataracts, very difficult to see the macula. You'll not be able to see the macula.
Yes.
We have found out in our study, in about 25 to 30% of the cases, we are able to pick up in cataract surgeries in preoperative evaluation, as high as 25 to 30% subtle changes like ERM, which has been missed by an indirect ophthalmoscopy or a 78 diopter or 90 diopter. So I think
it also
is a must.
Yeah, it also helps you to have a documentation that, the macula was okay.
Yes.
Because many a times I've seen a patient has developed macular hole maybe after 4 to 5 months, and then the patient has blamed the cataract surgeon. And if there is a documentation that your OCT was normal preoperatively, you can actually say that it is that way. So, VMT, we cannot pick up VMT very easily.
Absolutely.
Many a times. So I think OCT in every patient is important. And maybe you can go in for a cataract surgery earlier only if the cataract is preventing us from sort of monitoring the macular degeneration that is going on. And then in only that case, maybe under anti-VEGFs, we can go in for a cataract surgery earlier.
I think, Partha, as a scientific committee, you should bring out something like the AO preferred practice pattern as a guideline to the doctor, because otherwise already there is a patient complaints. You are doing OCT. I think Lalit put it in a different way, whether you charge or no charge. But I think machine costs, and then second patient should know we are doing it for their benefit and not for making money. We are doing an OCT. So I think we have to put a rule where it shows that we are interested in the health of the patient and our aging patient. And I think that's why we are saying it's recommended to do OCT. And they should not take it as that, because when people are doing OCT, so many times patients say, how you are, I think, charging every time for OCT. So I think he said it, include in the package. Maybe there has to be a cost, and cost accounting is important because the patient should know the machine is not coming free, no?
Absolutely.
And at the same time, I think we are helping a patient.
Right.
Superb thought, Dr. Natarajan.
Thank you very
Dr.
much,
Partha, we have a work to do now.
Yes. Yeah. No. You have enough work to do. So that we can.
One more work to do.
No, we have to safeguard our prestige as an eye doctor, because when somebody is advising OCT, now I don't know whether it is mandatory even in my hospital. I'm not sure. Because in spite of we have 4 retina surgeons, whether we are doing OCT for every cataract, I don't think so. Because I think it was a lesson to me today, but I don't know whether to, still I am thinking whether to advise every patient. Maybe AO should give a guideline, thinking, and I think like ICU also has a thing called position report, they call it, where 8 experts from various parts of India we should have, and make a document and publish it. And now we have IJO, you publish it and then give it to every person as this thing. So I have no prints now. Send as an document to every patient. And this is what our All India Ophthalmic Society has got a peer-reviewed publication.
Things like
Absolutely.
Fantastic.
Yes, very true.
Like one point, sir. The OCT can pick up unless you.
The patients with the normal macula, and only few patients with the VMT will not agree to it, Mohan. When the patient is happy, even sometimes VMT you have 6/9, some patients are happy, some patients is 6/6, they're not happy.
The advantage of OCT is the pre-operative documentation is very important.
No, I agree. What I'm saying, when you do daily, but one surgeon is not doing it.
Now. You need to have documentation.
Correct. No, I agree. What I'm saying, if the AOS scientific committee gives the homework as a document, if somebody is doing and somebody is not doing, and I think the patient, the doctor who's doing it will be protected, saying that he's doing not only for academic, He's actually doing it for the good of the patient.
Yeah.
Thank you, Dr. Natarajan, for a wonderful suggestion.
And the not doing surgeon might get sued also, sir.
Yes. That will be a problem also.
We need to use a very dictated, proper language.
We have to be scientific. I think.
That is why I said you have 8 experts, and you have a person like either Deshpande or Nirmal Frederick in one of the committee member, so that when they advise, the word has to be recommended, not must.
Absolutely.
Advisable.
Yes.
Let us